So again, just a reminder, the actual presentations are 7 minutes, and the short mini presentations are 3 minutes.
Okay, good morning. Thank you for the opportunity to present this research on behalf of my co-authors. I have no disclosures. Fluoroscopic guidance of TAVI deployment requires the use of nephrotoxic contrast agents as well as ionizing radiation. And this is of particular interest because many of the patients that present for TAVI deployment have underlying kidney dysfunction, and therefore in deployment of the TAVI valve, there is the potential for further kidney injury. We propose the use of a new guidance system that uses transesophageal echo, as TEE provides visualization of the valve function and does not require contrast use or ionizing radiation. However, with TEE alone, we do not see the TAVI stent or catheter clearly. Therefore, the purpose of our research project was to develop an augmented reality guidance system for TAVI deployment using transesophageal echo that achieves a similar deployment accuracy to the current standard of care, which is fluoroscopy, while eliminating the use of nephrotoxic contrast and ionizing radiation. Our proposed guidance system has multiple components. First, we used a tabletop magnetic tracker from Aurora or Northern Digital. 6 degree of freedom sensors were inserted into a transesophageal echo probe, and this has approval from Health Canada for insertion in humans. Next, we used a 6 degree of freedom sensor, also from NDI, that was inserted into the TAVI catheter, and a calibration block was printed from a 3D printer to determine the distance of the crimped valve from the sensor on the TAVI probe. We used a Philips IE33 transesophageal echo probe for biplane imaging. And from this transesophageal echo image, we generated geometric models of the aortic valve as well as a target plane, and models of the TAVI valve itself and stent catheter. And this was all shown on a common coordinate system shown here to the right. So now I'd just like to go through the surgical workflow. So the surgeon using this deployment system was asked to identify the 3 commissures of the aortic valve, which are shown here in yellow. Plane was generated, as well as the deployment plane at a determined target depth, which was set by the surgeon, and that's shown in red. Next, the TAVI catheter and valve were inserted through the left ventricular apex and represented here with a geometric model. And as the surgeon advanced the TAVI probe and catheter, they're shown here both in transesophageal echo image as well as with the geometric model, and you see that they line up nicely. You see that the surgeon is shown the remaining distance from the target plane, and as the surgeon becomes closer, the plane turns from red to green. And next, the orientation of the valve, the TAVI catheter, will be manipulated and shown in different views on transesophageal echo to confirm placement. So the objective of this particular experiment was to compare fluoroscopy versus augmented reality for transapical deployment of a TAVI valve using the AR guidance system versus fluoroscopy in an aortic root model, so not in vivo. A single cardiac surgeon was asked to complete 10 deployments of the TAVI valve in the aortic root model, and the model is shown there to your right. They completed the deployments using augmented reality and also fluoroscopic guidance. And following deployment of each TAVI valve, a camera jig with a reference checkerboard was used for position measurement. It was placed at a set distance each time. And using this, the distance from the commissure plane to the furthest visible stent strut was measured. So results, we found with fluoroscopy, we had to ask the surgeons to deploy based on a qualitative target. And they were asked to strive to achieve a consistent deployment depth. And with this, the standard deviation deployment depth for all 10 trials was estimated at 3.4 millimeters. With AR guidance, we set the depth at 5 millimeters using the guidance system. And with that, the standard deviation in deployment was 2.9 millimeters. However, most deployments were about 2 millimeters beyond the target depth, and this led to a higher root mean squared error of 3.4 millimeters. However, although this was larger, it was comparable to what we were achieving with fluoroscopy. So as you can see, there are several limitations to this experiment. We were using an aortic root model. It was not in vivo. It was a static model of the aortic valve. In addition, we were using a single Edwards Sapien TAVI valve as the model, and there was a small sample size. There are multiple strengths, I think, to this deployment system, though. With it, we're able to avoid the use of contrast and radiation. In addition, it is cost-effective and does not impede the normal OR workflow, as transesophageal echo is routinely used for TAVI deployment, as it is. So in conclusion, we developed an AR guidance system for magnetic tracking and intraoperative transesophageal echo guidance for TAVI deployment. We achieved similar deployment accuracies to fluoroscopic guidance in this aortic root model. And these results show that augmented reality guidance may achieve similar or better results than contrast-enhanced fluoroscopy while eliminating the use of ionizing radiation and nephrotoxic contrast. We have future work to do. First, we would like to complete these trials in a larger sample size. In addition, we have developed a feature-based registration for updating the real-time location of the aortic valve annulus so that we no longer have to use a static model. Furthermore, we've also integrated an ICE probe into the catheter as well for improved accuracy of TAVI deployment. We have those results as well. So I'd like to acknowledge these sources of funding, and I'm happy to answer any of your questions.
So for the interest of time, what we're going to do, we're going to put the two full presentations together and have discussions at the end. So can I ask for the next presenter from the group from